I thought I would talk a little bit about the updates that I got from the meeting and specifically focus a bit on some of the lectures on cardiovascular disease. But I'm totally happy to answer questions and talk about other things from the meeting as well. I hope people had a chance to see my post earlier from today where I wrote about some of the abstracts that I found. Well, a couple of the abstracts I found that were interesting, and one abstract that got a lot of press. And you may have seen headlines that made claims that if we start estrogen in the perimenopause, that we're going to reduce heart attack, stroke, and breast cancer by 60%. And all I can say is that abstract can't conclude that. And please read my post from earlier today. So the meeting was fantastic. The thing that one of the big take homes that I had was, man, there are so many amazing women in medicine who are studying medicine for women. And it was really a treat to hear so many amazing physicians and other health professionals talking about the work that's been done, about their work, and about the push to really understand differences in healthcare for women versus men. So that was really, I would say, just great. It was wonderful to get that. So one thing that was mentioned, which I found really, it's just something I had to think about, but we always talk about the sex difference in studies and how it's, first of all, we have funding differences and interest differences and all these other reasons. But one of the reasons why women are underrepresented in clinical studies is they're more likely to drop out because from citing family concerns. And I never really thought about that. And I just think that when we're designing studies, we have to try to level the playing field in all the different ways. But childcare and other family concerns disproportionately fall on women in many situations. And so just yet another reason that affects women in studies. So one thing that was discussed was that there is a change in lipids around menopause. That's when women start to have kind of a reversal in the trajectory and have an increase in LDL. And the one of the speakers brought up that this change in the trajectory of cholesterol around the time of the menopause transition is actually, when we start to see the change in the cardiovascular risk trajectory for women, right? That's when your risk of heart disease goes up. And she mentioned that for women, the total years of exposure to cholesterol is less because their trajectory where it rises happens later than for men. And I thought that was a really interesting point. I hadn't thought about it that way. And this was a big discussion about universal lipoprotein A testing being recommended for everybody once. You only needed to have it done once currently because it's a genetic marker, and it can help you put other risk factors in perspective. Your lipoprotein little a can rise around menopause, so having it done before can be helpful to give you, I think, more of a true risk, but just whenever you can get it is a good idea to do it. I know that not all insurances will cover it, and I've heard from people having difficulty getting it done, but it seems like the guidelines are changing or have changed, and so hopefully people will be able to get that test done. Another thing that came up was that white coat hypertension is not benign. So this is where you're in the doctor's office or any medical provider's office and your blood pressure goes up, but it's not up when you're at home. This represents sort of the continuum, I guess, of hypertension, and this is something to really discuss with your healthcare provider. It can overall increase your risk of having cardiovascular disease. So it's something not to be brushed off like, oh, you just have white coat hypertension, don't worry about it. It's something that should be monitored and it may need to be treated for some people. So just to kind of have that on your radar. Certainly, the question came up about menopause hormone therapy for prevention of cardiovascular disease. And this came up in a couple of sections. And it was not recommended for primary prevention of cardiovascular disease. We just don't have studies that support that. Definitely for other reasons, for hot flashes, for night sweats, and certainly helping people sleep through the night can be very important for lots of reasons. And sleep was a big focus of the meeting as well. But just for people to understand that. Okay, and let's talk about a few other things. So, diabetes reverses the age-related benefit that women get, a sort of protection from cardiovascular disease. So, if you're 45 and going into the menopause transition and you have diabetes, that actually sort of reverses the protection that you might get. So, treating diabetes is even more important for women from this standpoint. So to try to get not only aggressive care for your diabetes, but also the cardiovascular disease treatment that you may need, and certainly that's an indication for statins for women. There was a slide that was up that I thought was very definitive about supplements and LDL. And I get asked about that all the time. Should I take fish oil to lower my LDL? Should I take red yeast rice? And apparently, there's a study comparing several different supplements against one of the statins. And I mean, the statin was the winner hands down. And so supplements are not recommended for lowering your LDL. And then there was a really, excellent session on something that is often underappreciated or undertreated is young women who have what we call hypothalamic amenorrhea, meaning their periods are stopping because of signaling that's happening in the brain, or women with premature ovarian insufficiency, POI. So a condition that's really similar to early menopause. And in these situations, women are they're having very low levels of estrogen very early on. And there's a lot of things that biologically we don't understand. So, for example, it's really uncommon for those women to have problems with hot flashes, but they can have really significant early effects on their vasculature. And we believe that treating those women with estrogen is actually really, really important. But there's a lot of ongoing research here. And unfortunately, some of the studies that we have today are actually really quite small. So it was really interesting to hear from, somebody who's actually doing all the work and trying to understand things to make things, better for these women. So those are kind of the takeaways from the cardiovascular part of the session, which was there were three excellent lectures, and then also the excellent lecture on premature ovarian insufficiency and hypothalamic amenorrhea. So, does anybody have any questions about the meeting that you'd like me to answer or talk about? Anything else that came up? I'm happy to do that. And if not, I can just keep telling you about some more of the other things that happened at the meeting. So there was a lot of really great collegial discussion, I would say, from all of the speakers, and certainly the people really supporting other people's work, talking about the research that was done. Okay, so we have a question here. What's the lipoprotein test that you mentioned? It's called LPA, or lipoprotein little a. And it's just a one-time test. Uh, Somebody wants to know about androgens. So I wrote a post from the meeting about testosterone and sexual desire. And so you can go to that and read all of that there. And I am working on a post about Dr. Davis's lecture on just androgens in general. But if you have been a long time reader of the Vigenda, then she didn't say anything different than anything that I've written here. I mean, probably because primarily I'm citing a lot of her work, but that the data we have shows that testosterone, when given to women, does not improve muscle mass, does not improve bone density, does not improve cognition, and you only start to see improvements in muscle mass when you're pushing the testosterone levels high enough that you're skirting the male range. And so, in those situations, that you're going to get all of the side effects, acne, hair loss, weight gain, and those types of things. And so we don't have a recommendation to give testosterone that indication. And she is studying right now testosterone, I think, in the female range, replacing it in the female range for muscle. I do know she's got a clinical trial ongoing, Dr. Davis, and we have to wait for the results. Women deserve the science and they deserve, the quality data. And I think that there's been a lot of discussion about testosterone. I'm sure many of you have seen the article in the New York Times that was out last week. And, there were a lot of women or several women in there with obviously incredibly high levels of testosterone from some of the products that they were taking. And there was, of course, a discussion at the meeting about how testosterone pellets are absolutely not recommended because of the super high levels. So, what do you say to someone who said that they took testosterone and it changed their friend's life? Well, I think there's a couple of important things. So, I've discussed before in several posts and mentioned it many times that that there's a massive placebo effect with products, which is why we need to study them. For example, in the KEEPS trial, where they gave estrogen to women and measured irritability as a outcome measure, that there was a massive improvement in irritability with the estrogen, and also the same massive improvement with placebo. So I think it's really important that we have clinical trials so we can tell women. I think that the data that we have shows that there isn't an effect. And when people are saying that they're feeling dramatically better, I would worry that perhaps their testosterone levels may be higher than they're thinking. And we heard at the meeting how with people who get really very high levels, when those levels come down, they can feel terrible. They can kind of get like a withdrawal from that. And so I just think we need to do things in the most evidence-based, judicious way possible. And I think it's really difficult because there is so much disinformation on social media about the data that we have and a lot of cherry picking. And so we have fairly good data to recommend testosterone for low libido and low desire or difficulties with orgasm. And as I mentioned, I discussed that in an article I wrote a couple of days ago, and you can certainly go through that and see. And it's definitely worthwhile trying for that indication. So, I know everybody wants to have a magic thing, and I wish there were a magic. I think that it's really important that people can also get vocal changes from testosterone, and that can be irreversible. And I'm going to put this in an upcoming post, but there's actually a study for healthcare professionals for you to go in and answer questions if you know about the vocal changes that can happen with testosterone. Another thing that testosterone can do is it can actually raise your hemoglobin. And so sometimes I wonder if people who say they feel better on it have had a boost in their hemoglobin and maybe they actually had anemia that wasn't treated. That's just something that I've wondered. I don't have clinical evidence to back that up. So I always like to have that caveat there. And so it's really important when people, don't feel well to actually have an appropriate evaluation. And we know that low iron is completely undertreated for women. And many women may have anemia and they're not getting treated. So I think it's really important. Shout out to Dr. Gunter. Her talk at the meeting definitely had the most laughs. Well, that's always good to hear. Good to hear. How do I feel about adding testosterone to perimenopausal women on low dose birth control pills for libido? I wouldn't do that. I would say that if somebody is having libido problems on the birth control pill, and there's certainly the data is all over the place there. I would not. I would not add testosterone. I would switch them to a birth control pill without estrogen to see if that made a difference for them, or switch them to a different therapy, or try to switch them even from an ethinyl estradiol pill to the newer pill, Nextstellis, with estetrol. I think that's the name. I always get the trade names mixed up because that's supposed to have less of an effect on the liver proteins. So the whole way that the birth control pill is supposed to affect libido, and we don't really know. So I think it's like important to say that. Is it supposed to be because of its effect on sex hormone binding globulin? So sex hormone binding globulin is a carrier protein, and it carries estrogen and testosterone, and then we have free hormones in the blood. However, we now know that the way that testosterone binds to sex hormone binding globulin is different than what we thought. And it can also bind to albumin and other things. And so the idea that it's related to sex hormone binding globulin, we don't actually know. So So you can certainly try stopping the pill and seeing. But again, ethinyl estradiol has a more potent effect on sex hormone binding globulin, and the estetrol, the fetal, the estrogen that is the same as made from the fetal liver, doesn't have that effect. And so I think that would also be a really worthy switch for someone who still needs the estrogen. Somebody asked about menopausal hair thinning. So that was not a lecture that we had. And I would recommend that if somebody has thinning hair, that you actually have a discussion with a dermatologist, because there are conditions that can cause hair loss. It's also really important to have an iron level done, because low iron is associated with hair loss. And then for people who it's basically sort of age related, what is also called, I think, female pattern baldness, that low dose oral minoxidil is something that people have tried. Someone asked, can you still have low iron if your hemoglobin is normal? Yeah, I test people all the time with normal hemoglobins, and I am astounded at the number of people that have low iron. I mean, I'm absolutely astounded. So I think it's really important to check if people have symptoms. If you have somebody coming in, they have brain fog, they don't feel well, if they have hair loss, if they have restless leg syndrome, if they just don't feel right, that even if their hemoglobin is normal, I would check their ferritin. And if they have diabetes or health conditions, if they have obesity, then you probably should be doing additional testing, because ferritin is an acute phase reactant and it can rise in response to inflammation. And so I think that it's just important to understand that. And I have a post on how to screen people for iron deficiency. If you just Google that in the agenda, you'll be able to pull that up and see. Somebody wants to know if um, somebody is still having symptoms using a topical. I think that it's very hard to say, in this kind of format. I always say if people are having trouble with one topical and they're not getting relief of symptoms, that maybe you should switch to a different topical or try an oral to see if you get better improvement. Some people a small percentage of people just don't absorb well. And there was certainly a lot of discussion at the meeting from some of us old timers who have been doing this for a very long time, that Premarin, conjugated equine estrogens, seems to, in our experience, again, this is experience, so low grade quality evidence, seems to be really good for a lot of symptoms. And when transdermal doesn't work, and you're trying to switch to an oral, that might be a consideration to consider Premarin. So Dr. Davis and I had a long conversation about that. What about the supplement DIM? I can't answer any questions about that. I don't know of any kind of robust data about that, and it wasn't discussed at the meeting at all that I saw. There's always like a new supplement all the time, so it can be really hard to keep up. So I just think that's something to think about. And I'll have a more detailed post. I know there's always lots of questions on testosterone. I'll have a more detailed post on that coming up in the next couple of days from the lecture that addressed testosterone for other symptoms. Let's see. We also heard about the approval. I wrote about that in my post that was out earlier today, of the new neurokinin 3 and neurokinin 1 receptor antagonist for hot flashes. And so it's really exciting to have new choices. And I think that that it's really important, one, to have non-hormonal options, because not everybody does well with hormones. But two, the really exciting thing also about these drugs that I think we never talk about is the fact that when we give estrogen can have other effects on other parts of the body. And so when people have an improvement, it's always hard to pin down like why that's happening, right? But when we have drugs that target just kind of one really specific part of the body, when we give them, and then if we see there's benefits or not, that helps us really drill down. Is the patient getting a benefit because we're treating the hot flashes, or are they getting a benefit because of the estrogen? We can't tell that with estrogen, but we can tell that with the neurokinin 3 receptor antagonist. So we can say, well, we're only treating that one part of the brain. So if they're improving, it's probably likely because of this mechanism. So I think it's really interesting, because then we have this whole other way to study to study things in medicine. So someone said, I missed it. Are you not a fan of pellets? Or no, not at all. Uh, Pellets are not recommended by any menopause society. The um, Menopause Society in the US, the Australasian Menopause Society, like we don't recommend it. The current pellets that are made by compounding pharmacies. Their release of hormone is we don't know the manufacturing equipment that would be required to make one doesn't seem to be available at these types of pharmacies. The previous pellets, so years ago, they used to have a pellet that was made by a pharmaceutical company, and it was a completely different product. It was a lot sturdier. I've heard from people that the pellets break; they can break when they're inserted. They produce sky high levels of testosterone. Some people can have really male range levels, and it can take months longer for those levels to go away. So we don't recommend pellets. That really gives people inconsistent dosing and super high levels of testosterone. Somebody asked if there was any tips for people applying for medical school, for a medical student. Gosh, I applied, so long ago, right? So 40 years ago, I think. So I think what I did 40 years ago is a lot different than what's happening now. I would say that, just be true to yourself. That seems to be my best advice for everything. But because I'm not involved with really doing any medical student teaching, and because when I applied was so long ago, and also in a different country, I don't think I'd be able to be in a situation to give people any probably really constructive advice about that. I wish I could, but I don't. Um, all right. And let's see, let's see, are there any other questions there? What was the overall, let's see, what was the overall feel of the meeting? Oh, somebody last week you posted about the pill as an alternative consideration for hormone therapy up to 55. I'm 54. Yeah, at the meeting we said that we heard that up to 55 still held. I will say that that there is a study, it's a database study that shows that the estrogen containing pill is obviously associated with perhaps a higher risk of clots between the ages of 50 and 55. And this is a database study, so I don't want you to freak out about that. But the risk of your risk of blood clots increases with age. And we know that the pill with ethinyl estradiol has a more potent effect on the clotting factors. And because of the new pill with the estetrol that's available in the United States, and some countries have an estradiol pill, I would say that if it was covered by insurance, that at age 50, I might talk about switching to that pill if somebody wanted to. If they disliked it and wanted to go back to their ethinyl estradiol pill, I wouldn't have a problem with that. But I think if we're always trying to think about how can we be the lowest risk, then based on the fact that it has a minimal effect on clotting factors, if at all, the estetrol-based pill, I would probably recommend that. And they're investigating that dose of estrogen that's in the pill for menopause hormone therapy. So there was an abstract presented with that, and so we heard about how effective it is for hot flashes and about the effect on liver proteins. And so it looks like they're probably going to be getting an approval for that. They're going to be going for an approval. And so obviously if that dose is okay for menopause, then it's going to be fine for the birth control pill. Any discussion at the meeting about injectable estradiol? No. The injections all produce massive highs and come down. We don't have any safety data on that. You have to remember that all the safety data that we have with estrogen is based on, what we would call the moderate dose formulation. So 0.625 milligrams of conjugated equine estrogens, a 50 microgram patch, a milligram of estradiol. And so when we start using the injectables, we just don't have data on that to advise you. And that's just generally not something that we would recommend. I think something people often sleep on is in the United States, we have, I think it's called FemRing, the vaginal estradiol ring. And there's a 50 microgram and a 100 microgram ring. And so for people who feel like they're having difficulties with, transdermal absorption and don't want to use an oral, that's also another good option and just something to think about. So uh, I think people always forget it exists, and maybe because it have so many doses, or but anyway, it's a good option. So just something to think about. All right. Any other questions? Let's see. Um, as a doctor, do you consider drugs not approved by the FDA but approved in other countries like the UK? Um, so that's really a broad question that can't be answered. So if it's if it's not available in the country, then, it's obviously not something I can prescribe. So, for example, Androfem is available in Australia, and it's a good product to use when we want to give a female dose of testosterone. We don't have it here in the United States, so I can't prescribe it. We don't have Tibolone here, so I can't prescribe it. And because I'm familiar with transdermal testosterone because we have workarounds and use it, but I'm just not familiar with Tibolone because I've never prescribed it, because it's just I've been in the US for, almost 30 years. And so I haven't had access to it. So I can't comment on some of the drugs that just aren't available here because, I don't really know too much about them. I'm happy to look up and do some reading on some of, if somebody wanted to know about Tibolone, for example, but I'm probably not the best person to advise about it because I just don't have clinical experience. And so when I'm writing about things, it's not just based on what I've read, it's also based on, my extensive, clinical experience. And, sometimes we're mining old stuff. So, for example, someone left a question on my post, a recent post about using testosterone for endometriosis. And we don't have data for that, but we used to use danazol, which is an androgen. So it's like testosterone or has testosterone like effects. But we used that a long, long time ago, before we had the GnRH agonists and antagonists that were available. It certainly, wouldn't be wrong to use if you could get it, but people had really terrible side effects from it. And I think really the few people who stuck with it were the people whose endometriosis was just so bad that it was worth it for them. Or there are always some people, we're all biologically different, and some people maybe just didn't have the side effects from it. But certainly that medication has really fallen out of favor. All right. Well, I'm going to wrap things up in a few minutes. If there's a couple more questions that come through, I'd be happy to answer them. Otherwise, I'll have the post post on testosterone coming up. What's my thought about a half a dose of using vaginal estrogen? Well, I think that vaginal estrogen is, if you're well estrogenized from the dose that you're using, I think that's fine. I think that most of the vaginal estrogen products, we just only have short term data on. So, I think that if somebody were using, a once a week vaginal estrogen product and they were fine with it, I would say, like, why do we need to change things? And somebody asked about using a patch once a week versus twice a week. So I would only use medications from a patch standpoint because you're trying to get systemic estrogen as it's directed. So if you have a patch that's supposed to be used twice a week, that means that pharmacokinetically, by kind of 3.5 to 4 days time, you're now having, no estrogen, from the patch. The delivery is meant to be twice a week. There is a weekly patch, and if you prefer to use that, you can certainly switch to that. But I would always use things as directed. And there was a lot of discussion from some different people at the meeting about when you put a product in a different location, you get different absorption. So you shouldn't be putting, a lotion that's meant for the arm. If you're using, one of the estrogen gels and the package insert says to apply here, you shouldn't put it on other surface areas. It significantly changes the absorption. In fact, we heard some data. So way back in the day, people used to use topical testosterone for lichen sclerosis, and it's not very effective, and we don't use it anymore. People got sky high levels of testosterone from that. It absorbed incredibly well from the genitals. So I just think it's really important that we use products how they're tested. And in fact, when you go back and look at like the studies that are done about the different patches. They've looked at what happens when you put it on the abdomen versus put it on the arm versus put it somewhere else. And so you want to be careful and use it where it's been directed. So I think that's a really important. Um, what is the real deal on the brain one? One study said it hurts the brain at any age, and others says if you don't take it, you're going to get dementia. So there is no study that says that if you don't take menopause hormone therapy, you're going to get dementia. So I think that that is a really important thing to point out. We had a review again at this meeting, just like we did last meeting, from Dr. Pauline Mackey, that we have no indication to prescribe, menopause hormone therapy for prevention of dementia. We have at least four randomized trials, but I think there's actually a fifth one looking at cognitive function with starting menopause hormone therapy early, and no improvement was seen. There are some observational studies that show a small increased risk with use. These are from the European database studies. It's a very small increased risk, and these are observational studies, so people should not freak out about that data. So I would say that anybody who's telling you that menopause hormone therapy prevents dementia is operating in basically a data-free zone, or they're using really specific, uh, using very, very specific, observational studies. I reported on the abstract that shows that there was no brain shrinkage in menopause, which I thought was really cool. And there was also a paper just published this week showing that women's and men's brains basically have the same age-related shrinkage over their life expectancies. So, we're getting more data here all the time, but I think that in the absence of really quality clinical trials, people need to be really careful about observational data. And when I say people, I mean medical professionals and researchers, because observational data can have a lot of problems, and we just don't have the studies to tell us that. There are, and this was brought up at the meeting, many modifiable factors for dementia. There are many of them, and they can move the needle significantly. You can lower your risk by 50% by reducing or stopping alcohol intake, by getting exercise, by engaging in social activities. So all of these factors, and I've actually written about them before. There's also some pretty good data that shows the shingles vaccine can reduce your risk of dementia. It's not from randomized clinical trials, and obviously, that would take, pretty long-term follow-up, but the data is probably about as good as we can get from observational data. And I think that it's just really important that that we be careful about. But that being said, it's pretty good observational data. Basically, there was a natural experiment that was set up, where the vaccine, I think it was in Wales, became available and free, and so they could compare people who had an older vaccine versus the newer vaccine, and there was kind of a pretty dramatic uptake. Uh, switching from one to the other. And there's a pretty robust decrease in dementia with getting the shingles vaccine. So there are so many modifiable things you can do for your brain health. There are so many. So I would say that not to be discouraged about the lack of data about menopause hormone therapy, and instead be excited about all the things that you can do. Do I have a preferred menopause hormone therapy regimen? So I talk to people about their symptoms. I go based on age, but usually I start with uh, um, an estradiol patch, so a 50 microgram patch and 100 milligrams of progesterone a day. Obviously, I might vary things if someone is still cycling, because they can sometimes bleed all over the place. And so you have to have really an in-depth discussion about risks of bleeding, risks of endometrial cancer, and certainly, sometimes a progestin is a better option for that reason. So thank you everybody for joining. It was really a great meeting. I had a lot of fun. I met a lot of fantastic people there, and everybody was really just lovely. I was so impressed by the quality of the lectures and everything that was communicated to us. And we'll do another live, but look for my post on testosterone in the next day or two. Take care.